my clinical practice really is pretty much exclusively in the treatment of patients with substance use disorder. I run an opiate treatment program, methadone program. We have a large clinic here in Buffalo, one of the largest in the states that I run. And I have a fairly large outpatient practice in my primary care practice. It's a community health center that I do most of my outpatient medicine in. And in that setting, I treat a lot of patients with substance use disorder. I do a lot of training now in and around trying to improve access and education in and around this topic. So that's kind of where the comments are going to be focused more on the outpatient side. So that being said, my my experience now is as really in addiction medicine. It has not always been that way. I didn't have any kind of training in addiction medicine in my medical school time or in my residency. When I came back to Buffalo after my residency, I went into a primary care clinic, which is where I still work, community-based, socioeconomically challenged clinic, considered a mission clinic for the Catholic health system. And basically what I found very early in my practice, which was in the late 90s, I was right in the crest of this opiate crisis. And we were identifying it in our clinic very soon. And as basically as a way to try to survive all this, I'm seeing all these patients, all these different problems, pain, what appeared to me at the time, clear problems with substance use. I just started to try to educate myself. So I'm kind of self-taught in all this. And it basically evolved into my career really taking a total different trajectory than I ever planned. So that's kind of where I started. So I have a lot of experience treating substance use disorder in an outpatient setting. And as part of that, really what we're going to really be talking mostly about is using medication-assisted therapy, particularly buprenorphine, Suboxone. That is provided for by a federal law called the Data Act of 2000. I got trained in 2005, and so I was an early user of buprenorphine in clinical practice and have used it in my practice ever since. So as I said, now my practice has evolved to say really the ideal way I think that these medications should be used is by primary care physicians who are taking care of the primary care needs of patients and also treating them for their substance use disorder. And so that's really the way that I've always done it in my practice. And it evolved into basically this is pretty much most of what my practice, almost all of my patients have a substance use disorder. There is a very high demand for this treatment, and we're going to just sort of mention that. And these are areas where I think we just need a lot more research and thought about how we're going to change that. The crisis that we have now is multi-layered. One of the main things we need to do to address this crisis, though, is allow for patients who have this disease now, this chronic disease as we're talking about, opiate use disorder, for them to get into what is the most effective treatment, the medication-assisted therapies. And as it stands today in our country and in our Erie County in Buffalo, the demand is much higher than the ability to meet it as it stands today. So this part, one of the things I try to talk to primary care physicians about is that we are a little nervous about treating this disorder. We don't have a lot of training. We have misperceptions a lot of the times of what this is going to look like. And it is very, very rewarding. Because, like I said to primary care physicians all the time, I treat diabetes or say I have blood pressure, your blood pressure comes down. That's not very exciting, actually. You don't really, your life hasn't like turned around. So we see patients who are really in the throes of their addiction, and you treat them, help them to get stabilized, and it's a dramatic change in what is going on in a person's life when you're able to participate in that. So it's a privilege, honestly, to be a part of that. So the primary care setting, from my perspective, is the ideal place to treat this. It can be done in other settings, specialty clinics for substance use disorder and whatnot, but this is a chronic problem, and as I mentioned to primary care physicians all the time, that's our cup of tea. We take care of chronic disease, so this is where it should be done. There are a lot of challenges, of course, in all of this, and I'm obviously not going to be able to address all of them, but these are the three things I was going to highlight for our presentation today. Education in general, the increasing access really is the big thing from my perspective and what I spend a lot of time in, and then looking at really the challenge of taking care of these patients clinically. this is, you can read through some of these bullet points, but the point of this slide really is that we really don't get much education in medical training in general and in residency. And in my own medical training, very little. We had one presentation. I went to Dartmouth for my internal medicine residency. One presentation on chemical dependence, like a half a day. And that really is along the lines of what you see in the literature. All right, so the study that I'm quoting here in 2000, all right, not a lot of training. I think, well, hopefully things get better, right? This is a crisis and everything. You could see the follow-up survey didn't really show a lot of progress. And I think we're probably making progress now. I don't have any kind of data to show that, but obviously there's a lot more interest. But it starts with we don't get a lot of training early on in our careers, and then we go out into practice, and then we say, well, I am overwhelmed by this problem. I really don't know how to address it. And then it makes it, again, so that patients have a limited ability to access this care, because part of that is we don't really know how to treat it. And then, of course, the chronic pain training is pretty much the same, very lacking. There's been a lot of misunderstanding about the proper use of opiates, a lot of misunderstanding about how to properly prescribe opiates. So a lot of this starts with the education. And so one of the things is incumbent upon us to look at what we're doing here. What is the proper role here? How much of our curriculum should be devoted to this? I'm not sure, but some should be, definitely, and it's really not. I mean, my own experience I work at the Catholic Health System. We have a residency program, internal medicine, and it's basically like I've had to take a crowbar to get myself in there. So there's very little interest in learning about this in the program. One of the things that's always said to me is, well, it's not on the boards really. Well, that's true. But I mean, there's very little clinically, I would say, that is as relevant though. So we have to find a way to break through some of these barriers in our training. Dr. Bernstein mentioned, one of the things I've been doing with our residency program, I'm trying to get the residents all trained. It is not a model that's common. Pretty much no residency programs you can get trained to prescribe buprenorphine. I'm going to mention more, but Dr. Bernstein alluded to, it's really a pretty simple process. It's an 8-hour course. It can be done online. We've been doing some live trainings. I could do this for the residents, and even though they can't prescribe buprenorphine in their practice, they can, once they graduate from the residency, they could do it and they could be off and running. And there's just a lot of resistance to that because of time constraints and things like that. But it is the ideal time to incorporate it into our training, early on, because it's harder to the next slide, it's much harder to change practice that's already set, much harder, at least in my experience. So that gets to kind of the next point of educating physicians who have already, are already in practice. And this has been a big focus because of the seriousness of this crisis. And then when we look at the data from the state and in Erie County, it's pretty much it mirrors it. As we've been doing a lot of these trainings and trying to think about how we increase access, you look at the state, half the providers who can provide buprenorphine, half of them live in New York City. So the rest of the state, we already just got half the rest of us. And then there's 6 or 7 counties in New York State that have no providers in the whole county. So what do you do if you live there? And then one of the really big things that we're working on, and it's a little discouraging, is once providers get trained, so I get trained, I can provide buprenorphine, I could treat substance use disorder, opiate use disorder in my practice, only about a quarter of them after they get trained ever actually do it. And of those, only about the average number of people that they treat is about 8. So by the waiver, you could treat up to 100, I could treat up to 275, but the numbers of the people who get treated are then very small. So then this is one of the areas I think is we need a lot of thought on and further research on, is how do we get providers to change their practice? How do we get people to provide this absolutely life-saving medical care? How do we get them to incorporate that into their practice? So, I mean, these are just a couple of things to be thinking about, but I myself personally have thought about all kinds of different ways to do this. Is this something that we need to incentivize, give money to? I mean, that doesn't necessarily seem to work. The mid-level providers, now they can provide this care, so we're very hopeful that this will open the door up more, but it's not likely that that's going to solve all the problems here, given the restriction and access that already exists is probably not going to just make up the deficit. What are the best treatment models? This is one of the things we're going to talk about in our own data that we kind of gather from our trainings, that even after, so you go through this 8-hour training, it's not that surprising. Just like the motivational interviewing thing, it's not now like you're expert. And this is what we're finding, that, okay, I went through it, and yeah, I'm sort of feeling like I should do this, but I'm still not comfortable. So most providers want extra support. And how's the best way to give that? And how can we do it? What's the most efficient way to do it? How do we overcome barriers? There's a lot of barriers between insurance issues. How do I get reimbursed? Is my staff ready to do this? What's the record keeping and this kind of thing? So as part of that, as part of the opiate task force, a lot of what I've been doing is trying to increase training, and then by extension, hopefully, increase the number of people who are able to provide this care, and then increase access. So the Data Act, which we've been talking about, was the federal statute that allowed for the treatment of opiate use disorder in the outpatient setting. Up until then, in 2000, there was no ability to do that because it was illegal in this country to prescribe a controlled substance for the express purpose of treating opiate use disorder, any addiction actually. But so it can only be done in qualified centers like a methadone program, opiate treatment program. So this was a waiver to the federal law, and that's how this came to be about, allowing for, at this point, really it's buprenorphine for use in an outpatient medical center setting to treat opiate use disorder. It requires a minimal, really, of training, 8 hours for physicians, and it's 24 hours now for mid-level. So the mid-level training and ability to do this is brand new. It's just starting to be rolled out. So really not an extensive training, right? So we've been trying to increase our ability to do this. When we started to do the live trainings, there was 120 providers in Erie County or thereabouts. So not really that many, and as I say, only about a quarter were prescribing. So we started to think about what are some other ways. I mean, you could go, leave, get on the internet, any physician tonight, and do this. There's nothing magical about it. Why aren't people doing it? The thinking was maybe because it's on, a screen. I have no ability to ask any questions. That this is something that would improve people's willingness to do this. So as Dr. Bernstein mentioned, we've had a couple of live training now. We have trained 70 new providers. So that's a fairly dramatic increase if you think about it, in the number of people trained. The results, are been a little disappointing, though. Dr. Bernstein mentioned the initial wave of people we trained. When we did some follow-up of saying, like, okay, how'd this all go? They really weren't prescribing. They could have done it, but there were still a lot of concerns, questions, barriers to their willingness to do this. So this is just a little bit of the data that we found, and you can see these are the top 3 responses as to why an outpatient, these are primary care providers, why am I not treating patients with opiate use disorder with buprenorphine in my practice? And you can see these are the top responses. And so all of them said they need a little bit more help at their office, and all of them said they want some mentoring, and they feel like they want some more collaboration. And so then we've been trying to build these relationships in the community, in and around providers, to allow them then hopefully then to start to prescribe. We also developed, which was a kind of a new thing, a follow-up training that I specifically did with the people who have done the training, but it was open to anybody who has done it in the past and wasn't prescribing buprenorphine, to address specifically these questions. And preliminarily, the people who have gone through that training have said, yeah, I really, no kidding this time, I think I'm ready to prescribe. So one of the things I'm saying here is, hopefully you're getting a sense, this is a lot of work, actually, to try to do this, to draw this out. I've had about 10 or 15 of the providers from my original training in my office spending a half day with me, too. So this is the kind of thing that it takes, a lot of effort to try to get this out. And I'm working with Dr. Chang now, which has been really quite a pleasure, trying to look at some of this data, start to think about how can we look at what providers are thinking, how can we get them to sort of maybe start to change their behaviors a little bit. And this is really a joy to do, but it is a challenge. It's a challenge, and there's a lot of clinical challenges out there. Dr. Compton's lecture, awesome. One of the things, like one of the challenges I was going to mention, what happens when these patients have a pain problem? In our own hospital system, when patients with opiate use disorder, particularly if they're on medication-assisted therapy, end up in the hospital, which is commonly happening, we have that large methadone program, we have a very active buprenorphine prescribing, it basically causes chaos. It causes chaos for the staff, the providers who don't know what they do. Usually we pretty much do kind of the wrong thing. A lot of the times they end up getting their medication-assisted therapies withdrawn out of misplaced concerns about what that means for the patient. That translates, and I'm directly doing this now, that translates into a lot of behavioral issues in the hospital and directly involved with the nursing. So we're trying to address this, and one of the things is, how do we address it? What is the best way to address this? There's a lot of questions out there that are unanswered. What's the best way to address this complicated patient panel with all these comorbidities that we're talking about? They have hepatitis, they have other issues, a high preponderance of mental health disorders. What's the best way to do this? Should we collaborate within agencies? We've been trying to do that. Is this the most efficient way? A lot of people think kind of under one roof, if we can do it like that, where they could get all these services provided. But how does that look? Where does the funding come for that kind of thing? I mean, it's difficult. One of my sort of pet peeves is, how do we address behavior we don't like? We shouldn't be ever really surprised that a drug addict would use drugs. But this is what happens when there's a misunderstanding. So a patient comes in, start treatment, get on buprenorphine, they may be stable. A lot of the times, the most common clinical scenario is stable in my opiate use disorder, and now I use another drug, and a lot of times they'll get discharged from treatment. This dichotomy I'm saying is either you're in or you're out. And there's got to be a middle ground where we have reasonable interventions to try to address this. But we have very, very little, no training on that, and pretty much no guidance of what's the best way to address all these things. And then the sedative use is another one, big, big problem. Dr. Compton mentioned this co-prescribing with sedatives, particularly benzodiazepines, problematic. The problem is the preponderance of people who have a sedative use disorder have an opiate use disorder. What do you do when this already exists? Again, this dichotomy commonly, particularly in the methadone world, the patients will just be discharged. And that is not the proper approach. But we also don't know what exactly the proper approach is. This is part of the problem. So basically, you know, the primary thing I want to say is we should be doing this in primary care. To me, this is without question. It is not beyond us. It is absolutely clinically satisfying. But how do we provide the proper training to allow us primary care physicians to provide this care properly and, you know, comfortably? It's a comfort issue here in the primary care setting. So that's all I had to say. I tried to work through that quickly for Dr. Chang.